further ado, so the first person I want to introduce is Professor Peter Weimersheimer. He is the professor of surgery at University Vermont Medical Center. He's an EM physician. I met Peter through the Ultrasound Leadership Academy, and I consider him one of my mentors in the world of Pocus. So he is going to talk to us about an interesting topic that he actually wrote a chapter on in Scott Weingart's Resus Crisis Manual. So without further ado, this is Peter Weimersheimer. There you go, Peter.
All right. Hey, everybody. Thanks for organizing this. So I'm going to talk a little bit about a stuff here. I thought this for a little humor, Nick. This is how I just labeled my slide deck initially, but then as we were going on, I thought that this was more appropriate as the title. Are you seeing my slides move? You're muted.
Oh yeah, I can see that.
Okay. All right. So anyway, I've been thinking about this session, and those of us who are presenting here, we're kind of ultrasound zealots, and you had made this comment about how part of the purpose is to review ultrasound as an adjunct for critical patients for some skeptics. And as I thought about this, and I thought about what happens in our shop, frankly, some of these cases I'm going to talk about were my cases where I kind of kick myself and say, why didn't I go and scan the patient right away when I went into the room in the first place? And these were some near misses on my part. There's another patient that was a complete miss. And so I think as we're talking today, and the whole purpose is to just kind of review how we use ultrasound in the clinical setting and why and how we should use it. I thought these cases were appropriate. There is skepticism in the clinical community about when and how to use ultrasound. Why should I use it? Why should I pick it up? Is it really beneficial? I think those of us in the room are hopefully pretty committed to it. But there's still that debate is when am I using this and it's actually effective versus I'm messing around, especially as we're busy. And I think the ultimate thrust of this talk is going to be, why would you not? And what's the harm in putting some gel on a patient? It only takes a couple of minutes. In America, we actually bill for our studies. So there is the issue of ethics, and are you charging somebody money for something that's not helpful? But what's really not helpful is when we take care of patients, we don't figure what's going wrong with them. So here's some cases. All of you who are listening, have you think about what you would have done in these cases, and now we'll talk about what happened with them. The first was a 64-year-old woman. She has a history of fibromyalgia and chronic pain. She's had chronic shoulder pain for weeks. That's been accelerating. She's seen her PCP for that. And ultimately, the week of our evaluation, she had been prescribed some benzodiazepines, some methocarbamol, in addition to her pain medications. So a lot of polypharmacy for a chronic problem. And she got transported to us by EMS because her son found her altered. And on arrival, she actually has no complaints other than her shoulder hurts her. And she also says that she's just foggy, and she's actually really apathetic. I remember this, just kind of being struck by how she didn't really want to talk with us. She's just sitting there in bed, not really interested in anything, and acknowledging that she's apathetic. And in hindsight, read label indifference. So think about what you would do if you saw a patient like this. This is what we did. I was with a registrar. We did the usual. We got an EKG, put her on telemetry, did some blood work. She seemed a little punky, so we gave her some crystalloid, and ultimately walked out of the room wondering whether this was a polypharmacy issue. Is she now in the emergency department because has all these benzodiazepines and muscle relaxants and some opiates as well, and she's just overdone it. And so our plan was, reassess her and probably admit her to the medicine service and just see if things washed out or where this went. This is for you, Nick. This is Mr. Maldive with the Maldive pose. All of us have seen patients like this. He was at the gym working out, got about 10 minutes of chest pain, goes away. And he says, I don't feel like working out anymore. So he starts driving home and he calls his wife on the cell phone. She just says, you're not coming home. You're going to go get checked out. So he shows up in our emergency department and he truly had his hands behind his head on the gurney saying, I don't think I should be here. I'm fine. And because he had an episode of chest pain, again, this is what we do. He had a negative EKG. He was on telemetry. We did some blood work. We gave him a little crystalloid because what the heck, he was working out the gym. He's probably dry. And in terms of his workup, he had 2 negative troponins 3 hours apart. So this is a question to all of you. Think about how you manage a patient like this. By heart score or EDAX or any metric of cardiovascular disease, he can get sent home and he can go ahead and get an outpatient follow-up. And then finally, there was this gentleman. He was in his 70s. He's having breakfast with his wife. So read possible vagal syndrome. He gets really altered. His wife notes that for about 20 minutes or half hour, he looks pale, he's confused, he's almost falling over. She calls EMS. He's feeling better by the time they get there, but they measure these vital signs, so hypotensive. But by the time he arrives in our shop, he's better. He feels fine. His vital signs are okay, maybe a little low for someone who's older. He should have a little bit of a higher pressure. But concerning that he's an older patient, so the provider who sees him does the same stuff, right? Telemetry, EKG, some blood work, some crystalloid. And in the case of this guy, because he was a little older and higher risk stratification, they wound up getting a chest x-ray for a possible pneumonia. Was this a low-grade infection? They actually did a CT of his head and found nothing at all. So he was going to get admitted and obs on telemetry overnight. Our emergency department gets really busy. Our hospital gets busier. So he was in our emergency department for over 5 hours waiting for a hospital. Right? Everybody all comfortable with the way these cases are being managed, right? These are no-brainers, right? There's nothing really wrong with these patients, except that, all 3 of them, there's the common theme for all 3 of them is that they had something happen by the time they were being evaluated in our emergency department. Nobody had any complaints. Their vital signs are relatively normal. And the common theme in this talk is, well, they weren't quite all normal. And why didn't we just look at things and check things out a little more? And that was doing a bedside ultrasound as part of their initial evaluation. And so I'll go back, right? So the first patient, we're sitting there ready to talk to the admitting hospitalist, and we pull out the EMS run sheet, and oh crap, she was hypotensive in the field, and the EMS reports that she actually had been incontinent of stool. So this wasn't someone who was just altered. She was undifferentiated hypotension. And as we talk with other cases, how do I evaluate undifferentiated hypotension? Kian, you probably do the same thing, right? I get an echo. I look at the heart. And so sure enough, I put an echo on her chest. Anybody care to comment of the presenters here about what they're seeing on this echo?
You just see all this gray stuff, Peter. What is it?
It says gray stuff, and it's not a great image. This is done by a registrar, and it's on a patient who's lying supine. This is not a great picture, but right here, there is a pericardial effusion. It's a parasternal long axis view. There's this little bit of this black effusion right here around the heart. There is the descending aorta. That's not normal. So, okay, maybe, why would she have an effusion? And then if you look really closely and you cycle through it, her aortic root was enormous, right? Her aortic root is over 5 centimeters. Normal's around 3.4. So this is a woman now who's been lying in our shop for hours with pericardial effusion and a dilated aortic root. So the most likely diagnosis for this is going to be much more serious than her just having polypharmacy. One important point, I really think that as everyone learns ultrasound, there's this concept of a subxiphoid view as the view for effusion. I think that if you really want to see fluid and you have a supine patient on a gurney, that if this is transducer, there's gravity, that these parasternal windows are much more sensitive for seeing fluid. So there's not a lot of fluid, but enough to see something. How about this view? What view is this? Who can tell me that?
Subcostal.
This is her aortic arch. So this is an arch view, and I'll show you how to do this in a second. But you can see the curve here, and right over here on this arch view is this tiny little membrane. So this woman not only has a pericardial effusion and a dilated aortic root, but she has a dissection flap. We messed around with the handheld. You can see the same patient. There's a dissection flap. So she's been sitting in our shop for hours, dying of an aortic dissection. And, again, had undifferentiated hypotension, but we didn't ask the question. This gentleman, Mr. Maldive, right, he had undifferentiated chest pain and seems really benign. He feels fine, but our clinical exam set is limited. So what could I have done differently early on? Because I did this before I almost sent him out the door. I was going to discharge him. I wrote his papers up and I'm like, wait a minute. I do this all the time. Why am I not doing on this patient? And here's a parasternal long axis view of Mr. Maldive. It's not a great image. This is where the left ventricle should be, but you can see the RV and the LA and the aortic root. And oh yeah, look at this. His aortic root is 6 centimeters of dilated aortic root. And right over here is his dissection flap. So Mr. Maldive has been sitting in our emergency department, pain-free, normal vital signs, normal telemetry, 2 repeat negative troponins, and he's been dying of a dissection. And then there's finally this gentleman here who was observed for 5 hours until somebody, when you're observed in an emergency department and it's busy, that means you're kind of staying in the room by yourself. And his wife was there, unfortunately. And then she called a nurse because he was looking poorly and had horrible vital signs. And the provider runs the room and gets this picture here. This is a subxiphoid view, another view that you can see fluid. So here's liver, here is fluid, here's the cardiac view, and you can see his right ventricle is starting to collapse. So he is now in tamponade with a blood in his pericardium from his dissection. And unfortunately, shortly after this image was taken, he had a cardiac arrest and died. So, right, these were all patients who had come in with thoracic aortic dissections. And, the standard of care for emergency medicine, at least, is that we miss these on first go around. And why do we miss them? It's because they don't present like the book says. And by clinical exam, you're not going to diagnose a thoracic dissection for most of the time. You can feel for differential pulses or whatever you get trained on doing. And without looking more carefully at the root of the problem, no pun intended, you're not going to diagnose these. And so how do you diagnose the aortic dissections? Well, the simplest is to go ahead. I don't know why this is playing. The simplest is to go and do a parasternal long axis view. I think this is a great view for dissections because what you can look for in the parasternal long axis view is you can look at a nice aortic root here. And if the aortic root is normal in size, it's really unlikely that that patient's going to dissect. Those are really not described at all in the literature. And if you see that it's big, that can frame your management, especially if you see a pericardial effusion. Here's a tiny effusion at the base of this heart here. The other way you can do, which is kind of cool, is to do a arch view. And I do these a lot for patients who I'm concerned about dissection. I typically will start with a phase array transducer in the notch of the sternal notch, and I start sagittal. And then I'll just rotate towards the shoulder or left shoulder until I get this parallel view of the aortic arch right here. And this is not as sensitive as a TEE, but if you see a dissection flap, right? This is not playing. If you see a dissection flap in here, that frames your management, and off you go doing other things like getting blood products and controlling blood pressure and getting a surgeon available. Other places you can look, you can go down into the abdomen for descending dissections. They'll go down and they'll get into that abdominal aorta. So this is a sagittal view of an abdominal aorta just below the diaphragm. And there's a dissection flap. This was another case. A provider had a woman who came in, she was altered. And I'm not sure, I guess I have to go back and forth. Here it goes. She was altered. And he was actually going to put a central line in an internal jugular cannula. And as he was looking at her neck for the IJ right there, he happens to notice there's a carotid dissection flap and diagnosed the dissection by chance. And that's kind of the theme of the talk, better than luck than good. So quick overview of cases where doing ultrasound earlier would have probably been a little more helpful. And the idea, again, as we're having this conference today, talking about like, why do you do ultrasound for critical care? It really is, why don't you do ultrasound more routinely as part of just patient assessment? None of these patients had anything that was really specific when they arrived, but on hindsight, there were 2 patients who had undifferentiated hypotension and 1 patient had undifferentiated chest pain, and those should be automatic triggers to just take a look. At the worst, all of the looks would have been normal and none of these patients would have had what they had. But at the best, these were patients who 2 of them luckily got managed before they were admitted or discharged home for a fatal illness. The 3rd patient, no reassessment and no scanning before they finally had their tamponade from a dissection. So that's a quick overview. Happy to take any questions or discuss some of this. So thank you for all attending. I'm going to stop sharing the screen so we can all talk together.
So Peter, I've got a question for you. How accurate are you with TTE or transthoracic echocardiography at diagnosing, aortic dissections in the thoracic area?
I guess the quick answer, I have no effing idea. I think the point is with bedside ultrasound, for those of you who are learning or those of you who are skeptics or zealots, is recognizing a normal versus an abnormal. And if the question was truly, if the question was truly, does the patient have a dissection? It's not the correct test if it's normal. So, right. So you have to have humility about scanning. So if I think somebody has a dissection and I go ahead and do an arch view and I don't see anything, I'll do the CT angio if my question is if I have a high enough pretest concern. Right. So I'm not doing the ultrasound to rule it in specifically for a vague patient, but I have had, certainly, I can tell you now, I'd probably 20 cases of thoracic dissection where I've walked in the room and I've seen the flap in the arch and I've triggered management by the fact that I've seen the flap and I've gone forward. So what happened, our most, even for both of those cases, that gentleman, Mr. Maldive, he was in the operating room in an hour, right? So once I see that arch, I'm calling for blood, I'm managing blood pressure, I'm ordering a CT angio, I've called the surgeon, they're mobilizing the operating room, and it's a fast motion because these patients die quickly. And so what's nice about the ultrasound is as soon as you get your diagnosis, just you turn the switch on, and all these multiple aspects of care have to happen concurrently. And so you can start that process immediately.
So just in the chat here, we have a question from Tim's. Thanks for the question, Tim's. So the question is, any pitfalls with doing the arch view, and what do you need to watch out for?
So the biggest pitfall when I have a CT provider struggling with it is they're actually aiming the transducer too distally. So they take a really steep angle, they're pointing way down, assuming that arch is going to be down really in the belly. So the first pitfall is you're really not, it's a very slight angle. That arch is just by the sternal notch. So one pitfall is to just start with not a lot of angle on the transducer. And then the second is to remember that the aortic arch really goes from front right towards posterior left towards the back. So do that rotation of the transducer a little bit towards the left shoulder, and then just do a very gentle sweep around. I mean, the biggest pitfall is you won't see it. And I guess the second pitfall is as you were alluding to, Nick, is seeing normal and stopping there. So, it's actually it's not a difficult image to obtain, but I think the difficulty is being too steep with the transducer, and just, again, like anything else, just take your time and fan a little bit, and you have to look for that black area, right? That hypoechoic fluid or anechoic fluid, and then just focus on that by rotating or fanning a little bit, subtle motions.
Thank you for that. I think that goes back to this poem that I like to quote from the 1st century by this poem called Ovid, where he says, beware you need to treat the disease basically as early as possible, Otherwise, no amount of treatment is gonna get that sorted out once the disease has gained strength by long delay. So I think that like ultrasound certainly offers us that that tool in our diagnostic toolkit to get the diagnosis much quicker.
Right, and again, I think the whole point was that it's still treated sometimes as an exception, right? When do you bring it in? I almost routinely now bring my machine into the room of every patient I see. It clearly, if they have urticaria, that's probably not a reason to scan them. But for someone, especially has some odd story or something that doesn't make sense, there's no downside. And in all three of these cases, the benefit of scanning for someone who didn't have an obvious specific presentation was enormous.
Thank you for that, Peter.
Yeah, there's a question about a particular Pocus protocol.
Oh, yes.
I think the main, I think most of the protocols involve some sort of look at the heart or IVC, lungs, et cetera, et cetera. I think the protocol initially is going to be take a look. I typically start with the heart just in terms of getting a sense of cardiac squeeze. But and there's Kian is going echo first. Okay, Kian, why don't you just jump in and say just scan the freaking heart. But so you're looking at reasons that undifferentiated hypotension is going to be a pump problem, a circulation problem, a capacity problem. You can go in sequence. If you find your answer initially, then you can start framing that and managing, and if not, you go forward. So I don't use a particular protocol other than I start at the heart and start going depending on the patient in front of me.
Perfect. Thank you so much.